Hello. So, good morning, everyone. Thanks to Dr. Vishweswaran for inviting me to this forum. And what I'll be discussing with you in a couple of next 20 minutes is scoring PSG in adults and pediatrics. A word of caution, 20 minutes, I cannot teach you how to analyze the PSG. I can give you an overview of what all you have to look in the PSG when you're interpreting the data. Now, learning objectives for this talk will be, in the first talk you learned we need to identify sleep disorders. In the second talk, you learned about the instrumentation required for capturing the data from the patient. Once you have captured the data from the patient, you have to analyze the sleep waveforms, which were summarized by the previous speaker, but I'll just elaborate a little bit on that. After identifying the sleep waves, you have to do the sleep staging and arousal scoring. After doing sleep staging and arousal scoring, you have to do the respiratory event scoring. After respiratory event scoring, you have to do periodic limb movement scoring. Now, you have to keep in mind this sequence, please. Don't break this sequence. Like if you do a level 1 study, don't straight away jump to analyze the respiratory events. If you're doing a level 1 study, you have to go in this sequence to get the things correct. So in sleep waveforms, you identify the waveforms in EEG based on these 5 things. You have to know what is the amplitude of the EEG waveform, what is the frequency, what is the shape, in which leads their EEG leads they are present, and what is the duration of the wave. Once you know these features, you will be able to identify most of the sleep waveforms. So the first waveform that you have to identify is alpha waves. Now this screen that you see is called 1 epoch, which is of 30-second duration for sleep staging. On the left-hand side, you will have your EOG channels, you will have EEG channels, and then you will have chin EMG channels. So alpha waves are usually seen in the occipital lead with eyes closed. Like in EOG, you don't see any eye movements here. And alpha waves, basically, they have a frequency of 8 to 13 hertz in the occipital channel. And they come with eye closure and disappear with eye opening. Then you have got low amplitude mixed frequency activity, which is usually the background EEG activity, whether patient is in N1, N2, N3, or REM. So the activity that you see in this part, this whole region, this is all background low amplitude mixed frequency activity, which is usually very irregular, unremarkable, with the frequency of 4 to 6 hertz. The next waveform that you see is spindles. Spindles are usually seen in the central channel. They will suddenly come out of LAMF activity, like this zigzag lines. They will have a frequency of 11 to 16 hertz, and they usually last more than 0.5 seconds in duration. They'll suddenly come out of LAMF, like you see LAMF activity. Suddenly they will come out, and then suddenly they will stop. So this is how spindles look like. You can see a K complex. K complex is basically, again, coming suddenly out of LAMF activity, usually seen in the frontal channels. It has got a negative deflection going up, positive deflection going down, and then coming back. This component going up, down, and back is called K complex, and its duration is usually more than 0.5 seconds. Vertex sharp waves are usually seen in the central channels. They also have an up and a down component. They look like a K complex, but the difference is the duration of vertex sharp wave is less than 0.5 seconds. The slow waves, they are more prominent in the frontal channel, and the slow waves have a frequency of 0.5 to 2 hertz. That is, in 1 second, this is 1 second, you will have 0.5 to 2 waves. Now, another characteristic feature is slow waves have got an amplitude of more than 75 microvolt. As beginners, by looking at these waves, we don't know whether it is more than 75 microvolt or not. Then you can draw these reference lines in the software. Most commercial softwares allow you to do that. Now, these two lines any wave that crosses or touches both the lines will have an amplitude of 75 microvolt. So if you see over here, all these waveforms which are crossing both the red lines, they have an amplitude of 75 microvolt. So these are the slow waveforms. You will see sawtooth waves, mostly in the central leads, and they will look like the teeth of the saw with which you cut the wood. And they are usually present just before the rapid eye movement occurs. So in summary, you will see these kind of waveforms like alpha waves, LAMFs, spindles, K complexes, slow waves, sawtooth waves, and vertex sharp waves with these features. In EOG, you will see slow rolling eye movements. Slow rolling eye movements are seen over here. They're seen in both the eyes, and they just roll over slowly. And one of the characteristic features of slow rolling eye movements is from the time they start going up to the peak, this time duration is usually more than 0.5 seconds. So by measuring it, we will know whether this is a slow rolling eye movement or not. Another feature you have to keep in mind is, like previous speaker told you, when we place EOG electrodes, they are 1 centimeter out and 1 centimeter down on the left side, 1 centimeter out and 1 centimeter up on the right side. If you are placing your electrodes as per recommended derivation, the eye movements will always be opposite to each other. If one eye is going up, other will go down. If one is going down, the other will go up. They can never move in the same direction if electrodes are placed like that. Similarly, you will see rapid eye movements, which are basically a feature of wakefulness as well as REM sleep. During wakefulness, a person is scanning the environment, you will see these kind of movements. Now, the characteristic feature of rapid eye movement is it rapidly goes up. So the time from the deflection to the top is less than 0.5 seconds. If you see the slow eye movement, time from deflection to the top is more than 0.5 seconds. That will be a big differentiating feature for slow versus rapid eye movements. Reading eye movements are a feature of wakefulness. It's like reading a book. We start reading the book from the left side of the page, then go to the right side, and then quickly come back. So if you see here, this is going from left to the right, and then this is a quick deflection of right to the left. So you have got a slow component and a rapid component. Slow component, rapid component. Slow component, rapid component. Left to right, right to left. So these are reading eye movements. Now, these waveforms, they are not present right at birth. When a child is born, all these waveforms are not visible. So they appear at different point of time post-birth. Like spindles are most prominent at 6 weeks to 3 months post-term. K complexes are prominent at 3 to 6 months post-term. Slow wave activity is very prominent by 2 to 5 months post-term. Vertex sharp waves are prominent by 4 to 6 months post-term. What it is telling you is, in the first 6 months of life, you may not be able to see all the waveforms. Now, if you are scoring in infants, that is, infant, American Academy of Sleep Medicine defines it first 2 months of life. So if you're scoring infant's sleep study, there are additional waves called high voltage slow waves, low voltage irregular waves, mixed waves, and trace alternate pattern, which you have to identify for doing the sleep staging. Now, when it comes to sleep staging, if you have an adult and pediatric patient is 2 months to 18 years of age, you will be depending upon EEG, EOG, and chin EMG for doing the sleep staging. But if you have a pediatric infant patient, that is first 2 months of life, you will be depending upon EEG, EOG, and chin EMG, but you will always also need to pay attention to the respiratory pattern and the behavior of the child to do the sleep staging. And the sleep staging, there are 2 sets of rules. One is Rex-Sheffer and Kale rules, and the other is American Academy of Sleep Medicine rules. Like the first speaker told you, that Rex-Sheffer and Kale's, in 1968, they published a manual where they told how to do sleep staging. According to them, you have stage wake, you have stage non-REM, and then you have got stage REM. Non-REM stage, according to Rechtschaffen and Kales, have got 4 stages, 1, 2, 3, 4. This rules persisted till 2007. In 2007, American Academy of Sleep Medicine came up with their new manual, much based on Rechtschaffen and Kale rules only. The main difference was in adults, instead of saying non-REM have got 4 stages, they said there are 3 stages, N1, N2, N3. They combined 3 and 4 together into N3. The main reason given by American Academy of Sleep Medicine of combining 3 and 4 together into one stage was to reduce interscorer variability. Because the difference between 3 and 4 was very less, and many labs had an issue of saying the same epoch as 3, the other lab will say as 4. So they said to reduce interscorer variability, we are clubbing it together. There was no physiological reason given by American Academy of Sleep Medicine. In pediatric age, that is 2 months to 18 years, the stages are same. Only thing is non-REM sleep have got an additional stage called stage N. The reason for this is, I told you, different waveforms come at different ages of life. So during first 6 months of life, you may not see K complexes or spindles like if you have a child of 3 months old. At that time, when you cannot identify all the features, we usually call it as stage N. And if you have first 2 months of life, you have wakefulness, you have non-REM, REM, and transitional state. During first 2 months of life, non-REM do not have substages because there is not enough waveforms to differentiate N1, N2, N3 during first 2 months of life. So according to who your patient is, accordingly you have to use this nomenclature. Now for sleep staging, for wakefulness, the main criteria for wakefulness is presence of alpha waves for more than 15 seconds in the occipital leads. So if you see in this epoch, in occipital leads, I have got these alpha waves for almost entire 30 seconds. So if alpha waves are present for more than 15 seconds, we usually score this kind of epoch as stage W. Now, this is the most essential criteria. Rapid eye movements, eye blinks may be present, but they are not essential criteria. Most essential criteria is alpha waves present for more than 15 seconds. For stage N1, alpha waves needs to be replaced by low amplitude mixed frequency activity. So if alpha waves are replaced by low amplitude mixed frequency activity for more than 15 seconds, you score that epoch as N1. So what you see here, there are alpha waves in first 5 to 6 seconds, and then rest of the 24 seconds, you have got LAMF. So alpha replaced by LAMF, this epoch is scored as N1 because there are no spindles or K complexes seen here. Because if you have got LAMF activity, like if this epoch is N1, and I go to next epoch, let's say this is the epoch. So this first couple of seconds where LAMF activity is seen without spindles and K complexes is N1. But then we see a spindle appearing right over here. This appearance of spindle or K complex marks the beginning of stage N2. So I will have this portion as N2 and this portion as N1, which is coming from the previous epoch. So in this case, this kind of epoch where you see spindles or K complexes, we call it as first half. First half means in first 15 seconds, we score this as N2. The second situation will be, you have a epoch of N1 followed by an epoch seen over here. What you see here, there are no spindles or K complexes, but LAMF activity in this. In this epoch, you see a K complex towards the last part. In this case, what will happen is, this epoch is N1. When I enter this epoch, up till this point, I have got N1 stage. N2 is starting here only. Now, this epoch, what it will happen is, this is N1, this will also be scored as N1 because K complexes are in the later part of the epoch. And this K complex will have an impact on the next epoch scoring. For stage N3, you need slow waves for more than 6 seconds. Now, please keep in mind, what I'm saying is 6 seconds. I'm not saying 6 slow waves. Many people, what they do is, they just count 1, 2, 3, 4, 5, 6 slow waves and say this is N3. I'm not saying that. I'm saying that you have to measure the duration of, first you have to identify slow wave. Let's say this is 1 slow wave. You have to measure the duration of this slow wave. Let's say this is second slow wave. You measure the duration of this slow wave. This is third slow wave. You measure the duration of this slow wave. Add them together and then decide whether the slow waves are present for more than 6 seconds or not. If slow waves are present for more than 6 seconds, we score it as N3. Now, one thing you have to keep in mind is the waveform over here looks like a K complex also. K complexes are a type of slow wave. They can be counted towards slow waves to make a decision whether N3 is present or not. For stage REM, you need rapid eye movements in EOG, you need LAMF activity in EEG, and your chin tone should be low compared to non-REM sleep. If all the 3 things are present in the same epoch, that will be the first epoch of REM. Now, for the constraint of time, what I have taught you is how to identify first epoch of wakefulness, first epoch of N1, first epoch of N2, N3, and REM. There are 3 concepts that you have to remember. Identification of the first epoch, then continuation of the stage, then termination of the stage. Time constraint will not allow me to go through all that, but what I have done is, I have put my thought process into algorithms now. I have published this book where I have put in 13 algorithms for a beginner to start scoring. So entire thought process has been put into these algorithms. If you are interested, you can go through these. Sleep staging in infant, basically we have stage wake, N, R, and T. So there are specific rules for scoring in infants. Wakefulness, like I told you, you need to pay attention to EEG, EOG, and chin EMG, and the behavior also. So during wakefulness, the child may be crying or drinking milk along with other EEG, EOG, and chin EMG features. Stage non-REM, the behavior of the child will change and the waveforms in EEG, EOG, and chin EMG will change. That will allow you to score stage non-REM. Similarly, when it comes to REM, you will see rapid eye movements and the EEG features and the respiration will be bit irregular, unlike in non-REM sleep where respiration is very regular in the child. And lastly, if you are not able to see non-REM and REM features in EEG, EOG, and EMG, we call it as transitional sleep stage. There are certain combinations for that. When you're doing sleep scoring, sleep staging, you have to simultaneously do the arousal scoring also. You cannot do sleep staging without simultaneously doing the arousal scoring. Now, arousal scoring is basically, you have to score arousals in non-REM versus REM sleep. Now, in non-REM sleep, when you are scoring an arousal, arousal is sudden change in EEG frequency lasting for 3 seconds. Frequency change should happen in the range of alpha or more than 16 hertz, and it should be preceded by 10 seconds of stable sleep. What I mean by that, if you see in this epoch, I have got LAMF activity in this portion, then suddenly the frequency have increased here in the range of more than 16 hertz. So this frequency change that happened, this is my time scale over here. It is lasting for 5 seconds. This sudden change in EEG frequency lasting for 5 seconds, and before this I have got 10 seconds of stable sleep. This is how an arousal looks like in non-REM sleep. Arousal in REM sleep definition remains the same. Sudden change in EEG frequency, like in the range of alpha in this case, lasting for 3 seconds. In this case, it is lasting for 7 or 8 seconds. Along with this, your chin EMG should be elevated for more than 1 second. Then we score arousal in REM sleep. Now, American Academy of Sleep Medicine recently updated the scoring manual. So in 2023, version 3 has been published. One big confusion regarding arousal scoring used to be if this arousal, if let's say previous epoch is N1, I enter this epoch, and this arousal is lasting for 15 seconds or more. What do I do with that? The epoch becomes wake, and do I score the arousal in epoch wake? A big confusion used to be there. They have clarified in the latest manual that if arousal is preceding wakefulness, that is your wakefulness is because of arousal lasting more than 15 seconds, you will score the epoch as wake and score the arousal as well. They have made it clear in the latest manual. After doing the scoring, sleep staging and arousal scoring, the next part is the respiratory event scoring. Now, respiratory event scoring, again, I have given an algorithm. You have to identify apneas and hypopneas. In apnea, you have to identify obstructive apnea. In this, the previous speaker told you you're using thermistor and pressure transducer both. Thermal channel is used to define apnea as highlighted by the previous speaker. So this is my thermal channel, and my airflow have almost flattened. That is 90% drop in amplitude is there. This epoch is 2 minutes in duration. So this is 30 seconds, this is 30 seconds, this is 30 seconds, this is 30 seconds. So this flow absence is lasting for almost a minute. 90% drop in amplitude. Now, when the 90% drop in amplitude is there, this is apnea, we look at the effort channels, and you can clearly see effort is present throughout this apnea. So when effort is present, that is airway is obstructed, but chest and abdomen, they are moving, we call it as obstructive apnea. Obstructive apnea in pediatric patient definition is little different. In pediatric patient less than 18 years of age, we do not have 10-second duration for apnea. What we need is 2 missed breaths, and if effort is present, we will call it as obstructive apnea. Central apnea in adults is defined as drop in amplitude of 90% lasting for 10 seconds or more. That will be apnea. And if respiratory effort is absent, then we call it as central apnea. And one thing you have to keep in mind, if central apneas are not due to heart failure, there is something called cycle length that is beginning from the apnea to the end of the ventilation phase. This is usually less than 40 seconds. But in heart failure patients, I'll show you this changes. If you're scoring central apnea in pediatrics, the rule is very different. For pediatric, the duration, you have the following criteria. Either the absence of the airflow lasts for 20 seconds or longer, or the event lasts at least 2 missed breaths and is associated with an arousal, an awakening, or a more than 3% desaturation. This was not required for central apnea in adults. So in pediatric patients, what you see here is you have got an event which is lasting for 2 missed breaths and associated with from 96 to 92% desaturation, that is 4% desaturation is there. So this kind of event will be scored as central apnea in pediatrics. If you're scoring Cheyne-Stokes breathing, what you need is, this is usually seen in heart failure patients, you need crescendo, decrescendo breathing pattern separated by 3 consecutive central apneas or hypopneas with the cycle length of more than 40 seconds. Now this page is 10 minutes in duration, so this is 30-second duration, this is 30-second duration. If you measure this cycle length, it is coming to around 180 seconds. So cycle length is much higher due to heart failure, and this differentiates from primary central apnea, where cycle length is always less than 40 seconds. I'll just finish. Mixed apnea is basically you have got a central component first and then obstructive component, then we call it as mixed apnea. In adults, central will always be followed by obstructive. In pediatric, it may be central followed by obstructive or obstructive followed by central component. Hypopnea, you have got two definitions, recommended and acceptable. In recommended definition, airflow has to drop by 30%, lasting for 10 or more than 10 seconds, associated with 3% desaturation or arousal. In US, the insurance company says use acceptable definition because it is associated with 4% desaturation and not arousal. Now, hypopnea may be associated with desaturation only. Hypopneas are always scored on pressure transducer. My thermal airflow is absolutely normal, not showing apnea, but pressure transducer is showing more than 30% drop, lasting for 10 seconds, saturation falling from 99 to 92%. So I've got 3 hypopneas here. This hypopnea is associated with desaturation only. There was no arousal in the EEG. Whereas if you look in this case, this drop of 30% on my pressure transducer is not associated with 3% desaturation. From 99, it went to 97. 3% desaturation is not there. But if I look at the termination of this event and look at the EEG, clearly an arousal is present. That is why arousal need to be scored before you start scoring respiratory events. So this is an example of hypopnea with arousal only. You can have an event like this where desaturation is also there and arousal is also there. So you can have hypopneas with desaturation only, with arousal only, or with both the events. Hypopnea scoring, they usually, they nowadays say if, to differentiate between obstructive versus central hypopneas. So if you see this hypopnea, during this duration, snoring is present. So if snoring is present during the hypopnea event, we score it as obstructive hypopnea. Hypopnea in pediatric patient, there is only one definition, recommended definition. There is no acceptable definition in pediatric patient population. And lastly, you have to score PLMS. PLMS is basically movements like this, and you need 4 leg movements which are separated by 5 seconds, but less than 90 seconds. So if you see here, this is 30 seconds in duration. From the beginning of this movement to the beginning of this movement, it is more than 5, but less than 90 seconds. So I will say these are 2 consecutive movements. Then from the beginning of this movement to the beginning of this movement, I've got more than 5 seconds, but less than 90 seconds. So I call it 3rd consecutive movement. I have got 5 consecutive movements here. So I call this as PLMS sequence. And lastly, you have to do EKG scoring. EKG scoring till 2022, we used to score for sinus tachycardia, bradycardia, asystole, wide complex tachycardia, narrow complex tachycardia, and atrial fibrillation. But I always felt this is not sufficient because in the sleep lab, you can pick up heart blocks, you can pick up PSVT, you can pick up ventricular arrhythmias also. So we used to teach our students about more than what AASM scoring manual was recommending. And the good thing is in 2023, in version 3, they have clearly mentioned, please score heart blocks also and score cardiac pacemaker rhythms also. They have again not included the ventricular arrhythmias. I think they need another 1 year or 2 years to realize that that can also be recognized. And I think next update may have included the ventricular arrhythmias as well. I have developed 2 algorithms to make the life easy of students who are learning to score PSG. And lastly, after doing all this, you will click the button in this PSG, say report generation, and then you will have sleep stage parameter, arousal parameter. All this will be captured in numbers, and you have to make sense out of it, for which we have a different lecture. So I stop here. Thank you so much. I'm happy to take any questions.